Perfect.
Can you see my, can you see my?
Yes, perfect.
Yes, perfect.
I'm starting now. Thank you, Dr. S.K. Mukherjee. Welcome to session 2 of Paediatric Neurosurgery webinar series. It is organized by Neurosurgical TB and Department of Paediatric Neurosurgery. My heartfelt thanks to John Bennett and S.K. Mukherjee. I am Dr. D.M.Arman, work as the assistant professor in the Department of Paediatric Neurosurgery, going to present my topic on endoscopic third ventriculostomy with different scopes and endoscopic ventricular anatomy. This is our hospital. It is a 500-bedded hospital situated at Dhaka, capital of Bangladesh. Here, more than 40 neurosurgeons work here. In the last year, we performed near about 3,000 operations. In the operation theater facilities, we have 7 operating microscope, Medtronic neuronavigation system, and also have intraoperative neuromonitoring, Puja machine, C-arm, and all types of endoscopic setup, interventricular flexible and rigid endoscope. We have got recently latest tip-on-tip flexible neuroendoscope and various type of electrical craniotomy and drill system. Our director, Professor Kaji D.M.Arman sir, and Joint Director, Professor Bodrulam sir, they are renowned neurologists of this country. My heartfelt thanks to Director and Joint Director sir for their dynamic and dedicated leadership to ensure good working environment and to provide optimum full set of instrument equipments with latest technologies. In the Department of Paediatric Neurosurgery, from 2016 to till now, we did ETV is 292, and we performed more than 500 operations in the last year. The study of outcome of ETV is in progress. Introduction. Neurosurgery is a rapidly evolving specialty that often plays a leading role in adopting new technologies. Although CSF shunts are the most common surgical treatment for the hydrocephalus, a second surgical treatment option is endoscopic third ventriculostomy. ETV is one of the most widely performed procedure in neuroendoscopy. ETV is a technique to make an opening in the floor of the third ventricle, develop communication between third ventricle and preponderant system to bypass the obstruction to CSF flow using an endoscope. This is third ventricle. This is preponderant system. We make an opening in the floor of the third ventricle, communicate third ventricle to the basal system, that is preponderant system. History of evolution of neuroendoscopy. The first therapeutic application of endoscopy was in the field of urology in 1873 by Joseph Grunfeld from Austria. The roots of neuroendoscopy actually begin within the field of urology. Victor Darwin Lespines, a urologist in Chicago, utilized a rigid cystoscope in 2 infants with hydrocephalus in 1910. Walter Dendy, considered to be the father of neuroendoscopy, developed an open form of third ventriculostomy. He coagulated choroid plexus. The first ETV was performed by W. Jason Mixter in 1923. Victor Lespines, Walter Dendy, and William Mixter were the pioneers for introducing endoscopy in neurosurgery. Earliest instruments used for this purpose were cystoscope and urethroscope. The major improvements in the optical imaging was brought about by renowned British physicist Professor Harold Hopkins. The rights to his work on the lens system for endoscope were purchased by Karl Storch company from Germany in 1960. Takanori Fukushima used flexible endoscope in 1970, first biopsy in 1973. Griffith used rigid scope in 1977. The multipurpose ventriculoscope described by Henry Stroeder in 2008, he did interventricular lesion biopsy and resection in addition to ETV. Paediatric LOTA system from Karl Storch was conceptualized by Henry Stroeder. I have a good memory with renowned neurosurgeon Professor Henry Stroeder. He visited Bangladesh in 2019 to perform in live workshop in Bangabandhu Sheikh Mujib Medical University. It was organized by Bangladesh Society of Neurosurgeons. I must thank to present and past president and secretary and all executive committee members for their regular arrangement of such type of live workshop and international conferences. In this picture, beside him, I assisted him by holding endoscope. After operation, he appreciated for good assistance. It was a great moment for me. ETB is indicated in obstructive hydrocephalus. That means obstruction proximal to arachnoid granulations causes enlargement of the lateral ventricle and third ventricle, referred to as triventricular hydrocephalus. Primary cause is congenital aqueductal stenosis. Secondary cause may be neoplastic or vascular. Vascular cause is vein of Galen malformation, and neoplastic cause is mainly posterior tumor that causes obstruction to the aqueduct that causes obstructive hydrocephalus, and tactile plate glioma also causes obstructive hydrocephalus. ETB, other indication in managing shunt infection. This is posterior tumor obstructs the aqueduct and causes obstructive hydrocephalus. ETB also indicated in idiopathic fourth ventricular outlet obstruction. We did ETB 7 years back in patients with headache, vomiting, and blurring of vision. After operation, his vision is much improved. In her follow-up visit, recently we did MRI, ventricular size returns to normal, and he's clinically all right. This case report, idiopathic fourth ventricular outlet obstruction successfully treated by endoscopic third ventriculostomy. I published in Journal of Bangladesh Society of Neurosurgeons. ETB does not work in communicating hydrocephalus, where defect in the arachnoid granulations. ETB may not work if patient age is less than 1 year, because their subarachnoid space is less developed, may not work in emasculated hydrocephalus with small ventricle and in CNS infection. ETB not possible or does not work if abnormal anatomy or distorted anatomy is present, where basal system are not adequate, in narrow space present, or scarring or adhesion present, or in previous ETB failure, ETB may not work. There are two types of endoscope available, rigid and flexible. We have rigid endoscope and also flexible endoscope. There are few advantages of rigid endoscope. It has superior optic, more fiber optic, better image quality, several working channel. It has variable sizes, one size for adult and one size for pediatric patients. Disadvantage of rigid endoscope is lack of maneuverability. So we can approach only lateral or third ventricle. Advantage of flexible endoscope is it permits maneuverability or flexibility. We can approach lateral third ventricle, also aqueduct. Through aqueduct, we can see fourth ventricle and its contents. And through stoma of the ETV, we can see also basal systems. This is advantage of flexible endoscope. Disadvantage of flexible endoscope is it has limited fiber optic, poor image quality, and one working channel. We have rigid endoscope. This is used for adult patients. Its diameter is 6.1 millimeter, length 18 centimeter, working channel diameter 2.9 millimeter, irrigation suction channel 1.6 millimeter. It has fiber optic light transmission. It is sterilized by autoclave. This is operating sheath or obturator sheath. This is obturator. Its outer diameter is 6.8 millimeter, length is 13 centimeter. This is little Lota ventriculoscope used in pediatric patients. This is less diameter, outer diameter 3.6 millimeter, length is 18 centimeter, working channel diameter 1.6 millimeter, irrigation suction channel 0.1 millimeter. It has fiber optic light transmission. It is sterilized by autoclave. This is operating sheath or obturator sheath. Its diameter is 4.5 millimeter, length is 30.3 centimeter. This is obturator. Advantage of little Lota ventriculoscope is narrow diameter. We can approach in narrow foramen of Monro in adult, also pediatric patients. This is earlier version of flexible endoscope. Its outer diameter 3.7 millimeter, working channel 1.5 millimeter. It deflects 120 degree down and 170 degree up. This is narrow diameter catheter. This is two working channel, light source attached here and camera head attached here. This is steering. Steering causes movement of this catheter in two direction. This is flexible monopolar electrode called Bugby. Its diameter 5 FR, working length is 53 centimeter. It is used in flexible endoscope to fenestrate the floor of the third ventricle, also hemostatic purpose. We have got recently, this is latest chip-on-tip flexible video neuroendoscope. Earlier version of flexible endoscope has limitation. It has poor image quality. This chip-on-tip flexible video neuroendoscope has overcome it. It has improved visualization, high definition camera, integrated LED light source, so no light cable needed. Its outer diameter is only 2.9 millimeter, elliptical end tip, working length 35 centimeter, working channel 1.2 millimeter. 1 millimeter flexible instruments are used in this neuroendoscope. It is sterilized by ethylene oxide. It has advantage, it enhances visualization and used in narrow foramen of Monro in adult, also pediatric patients. And in addition to ETV, we can do tumor biopsy through flexible neuroendoscope. How we do endoscopic third ventriculoscopy? ETV is performed under general anesthesia. Patient is positioned supine with head placed on a headrest, elevated to about 30 degrees. Surgical site is prepared. curvilinear incision is made at Cocker's point, 1 centimeter anterior to the coronal suture and 3 centimeter away from the midline. If we do aqueductoplasty, bar hole is placed more anteriorly, 2 to 4 centimeter anterior to the normal usual site. A bar hole is made. Location of the bar hole may be adjusted by navigation in order to optimize the trajectory for making the third ventriculostomy. Dura mater is opened by linear incision. Margin is aparted. Pyometer is coagulated. Brain cannula is inserted into the frontal horn of the lateral ventricle and dilated the cannulation with brain cannula. After entering into the frontal horn of the lateral ventricle, we found this is cord plexus, this is thalamus-striate vein, this is septal vein, this is foramen Monroe, and this is fornix. During endoscope manipulation, pharyngeal injury may occur that causes memory impairment in the form of retrograde amnesia. After entering into the third ventricle, mammillary bodies, basilar artery, translucent tuber cinerarium, and dorsum sella and infundibular recess are identified. If this structure cannot be visualized, then procedure should be aborted. The site of fenestration is chosen more anteriorly to avoid vascular injury to the underlying basilar artery. Floor of the third ventricle is fenestrated with bipolar or unipolar electrode. This is bipolar electrode. Only gentle push make the fenestration. No need coagulation. If needed, care must be taken from diathermy injury to vital structures. This is the Fogarty balloon catheter. A 2 or 3 Fogarty balloon catheter is used to dilate the opening. Balloon is inflated distal to the opening in the floor and is then withdrawn through the opening. Opening is 4.5 millimeter is usually enough. When we inflate the balloon, usually it slips sometimes down and sometimes up. Inflated balloon, when it feeds the margin of the opening, it effectively dilated. After fenestration, sometimes second membrane is found. This is called Lilliquist membrane. This is also opened if present. After fenestration, we can see this is basilar artery and perforators. After completion of the ETV, pulsatile flow of CSF is observed through the opening into the floor of the third ventricle. This is mammillary body, this is basilar, this is tuber cinerarium that forms the floor of the third ventricle, this is infundibular recess. The ventricles are inspected for any areas of hemorrhage and are obviously irrigated before removal of the endoscope. Dura is closed in watertight fashion. We usually do dural closure is reinforced with pericranial strip. Now I will show few cases where I did ETV. First case is 15 years old male presented with headache, vomiting, blurring of vision. MRI of brain showed triventricular hydrocephalus, and this is tactile plate glioma, which obstructs the aqueduct and causes obstructive hydrocephalus. We did ETV with rigid endoscope, that is Paediatric size little lotar ventriculoscope. After entering into the lateral ventricle, this is cord plexus. This is perforated septum pellucidum. This is thalamus-striate vein. This is septal vein. This is foramen of Monroe, fornix, anterior column of the fornix. We enter into the third ventricle. This is mammillary bodies, tuber cinereum, translucent. This is floor of the third ventricle. This is basilar top. And this is dorsum sala. This is infunicular recess. First, we see ventricular anatomy. Then we can choose site for fenestration. We use bipolar electrode for fenestration, just gentle push, no need energy. Just gentle push, make a opening. Opening is already created. Now opening is dilated with Fogarty balloon catheter. This is balloon catheter 2 or 3F. Balloon is inflated to dilate the opening. Often it slips down or slips up. It dilated effectively if inflated balloon fits at the margin of the opening. After completion of ETV, we can see basilar artery through stroma. You can see pulsatal CSF flow is observed through stroma of the ETV. Next case, 3 years, 2 months old male presented with headache and vomiting. CT scan showed obstructive hydrocephalus and Dendy-Walker malformation, Dendy-Walker variant is seen. We did ETV with rigid endoscope, paediatric size. After entering into the lateral ventricle, we can see this is thalamus, which forms the lateral wall of the third ventricle. This is thalamostrate vein. Deficient septum pellucidum. Cord plexus of the opposite ventricle is seen. This is foramen of Monro, fornix. Cord plexus goes down to the temporal horn. This is chordate nucleus, component of the basal ganglia. which forms the lateral wall of the frontal horn of the lateral ventricle. This is anterior column of the fornix. After entering third ventricle, we see two medullary bodies and basilar artery with posterior cerebral artery and its central branches. This is oculomotor nerve. This is oculomotor nerve. This is translucent tuber cinerarium, which forms the floor of the third ventricle. This is dorsum stella, and this is infundibular recess. This is chiasm. This is chiasm. We usually choose for fenestration in between dorsum stella and basilar artery. With rigid endoscope, it is hard to move behind. This is interthalamic adhesion. This is cerebral aqueduct. During manipulation of rigid endoscope, care must be taken to avoid pharyngeal injury. This is thalamus. This is thalamus, which forms the lateral wall of the third ventricle. This is bipolar electrode. Try to make an opening in the floor of the third ventricle. I tried to dilate the opening with this bipolar electrode. There is a second membrane. There is a second membrane. This is called Lilliquist membrane. It is also opened. And there are other perforated membrane also present. We try to open all membrane. This is abduction nerve. This is abduction nerve. You can see and this is basilar artery with perforators. This is abduction nerve, sixth nerve. You can see pulsatile flow already established. We try to make more opening in multiple membrane below the floor of the third ventricle in preponderant system. You can see pulsatile flow of CSF is observed. Again, we see this is interthalamic adhesion. And this is thalamus. This is cerebral aqueduct. It is difficult to go far behind with rigid endoscope. Care must be taken to avoid pharyngeal injury during endoscope movement. Anterior column of the fornix. This is white matter band connects hippocampus to mammillary body, fully deficient septum pellucidum. This is dorsum sella, floor third ventricle, basilar artery. This is chiasm, interthalamic adhesion with aqueduct, cerebral aqueduct, posterior commissure. This is oculomotor nerve below the posterior cerebral artery. This is thalamus. This is abducens nerve. This is basilar with its perforators. Fenestration is done. This is thalamus, thalamusted vein. This is chiasm. Basilar artery with its perforators. Correct plexus enters into the third ventricle. This is oculomotor nerve, just below the posterior cerebral artery. Next is 8 years female presented with headache and walking difficulty. It can show triventriculomegaly. We did ETV with rigid endoscope. Entering into the lateral ventricle, see deficient septum pellucidum. Cord plexus of the opposite ventricle is seen. This is thalamusted vein. Cord plexus goes down to the temporal horn. This is frontal horn. This is caudate nucleus. This is caudate nucleus. Forms the lateral wall of the frontal horn of the lateral ventricle. This is anterior column of the fornix. This is thalamus. This is thalamus. You know, fornix is a white matter band, connects hippocampus to mammillary body. We go inside the third ventricle. This is mammillary body, basilar top, translucent tuber cinereum. This is dorsum sella. This is infundibular recess. This is optic chiasm. This is optic chiasm. Above the optic chiasm, this is lamina terminalis. You know, lamina terminalis is a thin sheet of gray matter. Behind, we can see this is interthalamic adhesion. I mentioned earlier, care must be taken during movement of the rigid endoscope. We try fenestration with electrodes. Try to make it dilate with balloon catheter. fenestration is done, there is so much scar in preponderant cistern. There is a fornix condition of the fornix. During manipulation of the rigid endoscope, it causes fornicial injury. Fornicial injury may cause memory impairment in the form of retrograde amnesia. This is optic chiasm. Contused fornix. This is optic chiasm above lamina terminalis. This is infundibular recess and above optic chiasm. This is lamina terminalis. This is optic chiasm. Lamina terminalis forms the anterior wall of the third ventricle. This is interthalamic adhesion or massa intermedia, which connects the two sides of thalamus. This is anterior column of the fornix. This is thalamus. This is thalamus-straight vein. Again, optic chiasm. This is infundibular recess. This is lamina terminalis. It forms the anterior wall of the third ventricle. This is aqueduct, thalamus-straight vein, and this is caudate nucleus. This is earlier version of flexible endoscope. It has narrow diameter, but it has limitations, less fiber optic, poor image quality. We did ETV with earlier version of flexible endoscope. Vision is slightly poor than rigid endoscope. We enters into the third ventricle. ETV is already done. Through stoma of the ETV, we proceed in preponderant cistern. Advantages of the flexible endoscope is it has more flexibility. We can move anteriorly, posteriorly, and see surrounding structures more than rigid endoscope. Through opening, we try to see inside the preponderant cistern. This is basilar artery and its perforators. You see, this is below, this is vertebral artery. This is vertebral artery on both sides unite to form basilar artery. It is not possible with rigid endoscope. Go inside the preponderant cistern. As narrow diameter of flexible endoscope, more flexibility, we can approach through opening into the preponderant cistern. We try to break the band of arachnoid with monopolar electrodes. Again, you see, this is vertebral artery. On both sides, you need to form basilar artery. flexible endoscope. Earlier version also beautiful endoscope, but it has some limitations. It has poor image quality. Next case, 3 years, 6-month-old female child presented with headache and vomiting. MRI of brain showed there is a posterior fossa tumor, obstructs the aqueduct and causes obstructive hydrocephalus. This is posterior fossa tumor. And we did ETV with flexible neuroendoscope, chip on tip. We have got recently. It has advantage, improved visualization, high definition camera, integrated LED light source. So no light cable needed, smaller outer diameter is only 2.9 millimeter. So we can use in narrow foramen of Monroe in adults and also pediatric patients. This is the working channel of chip on tip neuroendoscope. It is endoscopic catheter. No additional camera head is needed. We ETV with this chip on tip flexible endoscope enhances visualization. Chip on tip flexible endoscope has overcome earlier version of flexible endoscope. It enhances visualization, high definition camera, so we can see clearly. This is lateral ventricle. This is cord plexus, thalamostrate vein, fornix. After entering the third ventricle, this is basilar artery with posterior cerebral artery, two medullary bodies, dorsum sella, infundibulum recess, and this is oculomotor nerve. And this is oculomotor nerve below the posterior cerebral artery, and this is optic chiasm. Behind, this is thalamus, this is cerebral aqueduct, and this is posterior commissure. You know, it is white matter band connects to cerebral hemisphere, and this is spinal recess. And behind, this is heavinular commissure. This is also white matter band connects to heavinular nuclei, and this is suprapineal recess. This is suprapineal recess. And internal cerebral vein confluences to form vein of Gallen. And it is posterior part of the third ventricle. It contains choroid plexus also. And through a cerebral aqueduct, we can see fourth ventricle. And this is tumor. This is tumor. This is tumor. Aqueduct is hugely dilated, so we can easily go through aqueduct and see the fourth ventricular content. This is thalamus. This is thalamus. This is thalamus. This is pecum. This is pecum artery. Again, we can see this is frontal horn. This is caudate nucleus. This is caudate nucleus, component of basal ganglia. This is septal vein, thalamostrate vein. Due to flexibility of flexible neuroendoscope, we can see around easily. You can see narrow preponderant cistern, basilar artery compresses the dorsum sala. So in these cases, though transparent tuber cinerarium, so care must be taken to fenestrate the floor of the third ventricle. This is infundibular recess. I tried to make fenestrate on either side of the basilar artery. This is monochloride electrode called BUG-P. Opening is already created. Again, we try to see posteriorly. This is aqueduct, this is thalamus. This is posterior commissure. This is spinal recess. This is heavinular commissure. And this is suprapinal recess. And this is optic chiasm. This is optic chiasm. Anticon of the fornix go behind to form body of the fornix. This is looks strange, whiter appearance. This is thalamus. This is thalamus. Fornix. This is caudate nucleus. Chord plexus, septum pellucidum. Infundibular recess and anteriorly optic chiasm. This is thalamus-straight vein. Posterior commissure, anteriorly cerebral aqueduct. This is internal cerebral vein confluences to form the vein of Gallen. This is suprapinal recess. This is oculomotor nerve just below the posterior cerebral artery. This is thalamus to mammillary body. Again, oculomotor nerve. Optic chiasm. Cerebral aqueduct behind posterior commissure. This is thalamus. Through cerebral aqueduct, you can see the tumor. This is dilated cerebral aqueduct. Infundibular recess, dorsum sala, basilar artery, to mammillary body, thalamus, and this is pecum. This is pecum. This is posterior cerebral artery. This is oculomotor nerve. Complications are hypothalamic injury, injury to the pituitary, stroke, transient third or sixth nerve pulses, injury to the basilar artery, injury to the pecum or PCA, hemorrhage can occur. Damage to fornix during manipulation of endoscope causes memory impairment in the form of retrograde amnesia. Infection may occur, fever may occur. In management of hydrocephalus, following BP shunt, the size of the ventricle decreases quickly, then ETV. So follow-up MRI of brain 6 weeks to 2 months later reveal resolution of ventriculomegaly. Sagittal T2 weighted thin slice will show dropout of T2 signal at stoma of ETV. Children may be followed intermittently in the post-operative period with MRI of brain. Success rate in literature is range 6 to 94%, average is 56%. Success rate in infants may be poor because they may not have normally developed subarachnoid space. low success rate if existing pathology includes tumor, previous shunt, previous subarachnoid hemorrhage, whole brain radiation, significant scarring or adhesion in basal system. ETB success score predicting the success of the ETB. It based on 3 factors: age of the patient, etiology of the hydrocephalus, and history of the ventriculoperitoneal shunt. It comprises total 90% score. Score less than 40% correlated with very low chance of success. Scores more than 80% correlated with a better chance of success. In conclusions, endoscopic instruments and optics have improved significantly. The complications of infections and shunt malfunction associated with CSF shunt systems remain persistent source of morbidity and mortality in children. And in an effort to reduce the shunt burden in children, neuroendoscopy has seen a resurgence in its use in the past 2 decades. This is end of my talk. I am stopping here. Thank you very much, everyone.
Thanks, Dr. D.